Early childhood development is a multidimensional concept, which means different things for different people. From Thrive's perspective, we want to look at it holistically, ages from conception to age 8. We focus on health, nutrition, early learning, responsive caregiving, and child safety and security as drivers in the child development process. In terms of outcomes, we look at things like health, nutrition, cognition, and socio-emotional development.
We know that early childhood interventions can be very effective and have persistent, large effects on a multitude of outcomes. What we don't know is how to adapt these models to be able to implement them at scale within the tough constraints of the poorer countries.
Scale-up by itself is a science. It must be planned. We must look at the factors that enable it and how do we give it the best possible chance of success. We have to influence policy, and policy thrives on evidence. And I believe that's the gap that Thrive will be able to fill. Where there is anecdotal evidence, it's an opportunity to test it and be able to provide policymakers with the information that allows them to confidently make policy choices, and in particular invest the limited resources that the country has, because they know that this is backed by science, this is backed by evidence.
To find out more or support this project, get in touch.
Hello everyone, and welcome to the 5th edition of the Thriving Conversation webinar. My name is Beth Kayes. I'm a senior researcher at the Christian Michelsen Institute in Norway, and I'm also research director on the Thrive program. So for those of you who are new to Thrive, we are a multi-country research program that is entirely focused on scaling early childhood development services in low and middle income countries. Thrive is funded by UK's FCDO, and it's co-funded by New Zealand's MFAT. As part of many great Thrive initiatives, each month we organize a Thriving Conversation webinar to bring together researchers and policymakers to discuss recent, fresh from the press scientific advances on scaling ECD. And our focus in this webinar series is on what it takes to move from small, successful pilots to sustainable national programs while maintaining quality at scale. And across the webinar series, we explore programs that are at different stages along what we call the pathway to scale, and we reflect on the lessons and challenges that emerge along that journey. Today, we are really honored to welcome very special guests to our webinar series. It's a team that is working on one of the very few parenting models that has reached the stage of embedding the intervention into government systems. And in fact, they are the first ones in our webinar series to have reached this particular stage in the scaling journey. And with they, I am of course referring to Jamaica's ReachUp team. Anyone working on ECD will be very familiar with the pioneering ReachUp parenting program. So ReachUp's journey began a long time ago in Jamaica, already in the 1970s, with a home visiting intervention, which at the time was delivered by doctors and nurses, but then in the 1980s was adapted for delivery by paraprofessionals using homemade toys. The results of that trial were groundbreaking and extremely influential, with adaptations and replications all around the world. Today, the question is no longer whether ReachUp works. We know it works. The question really is how to scale it effectively. So in collaboration with Jamaica's Ministry of Health and Wellness, the ReachUp team has now developed a 5-year scaling plan, which we believe is an inspiring example of research policy partnership in action. And I think all of us can learn a lot from this partnership and its journey. And that is exactly why we invited the ReachUp team to our webinar today. We are very pleased to welcome Professor Susan Chang and Professor Joanna Smith, both from the University of the West Indies in Jamaica, where ReachUp is hosted. So welcome, Susan and Joanna, and thank you very much for joining us. We're also joined by Dr. Julia Rowe Porter, who is Director of the Family Health Unit at Jamaica's Ministry of Health and Wellness. Welcome, Dr. Rowe Porter. Also you, thank you very much for being here. Today, we'll begin with a short 15-minute presentation by Susan Chung on the ReachUp program and the results of the team's latest trial, which is about a blended model integrating home visits and phone calls into the primary healthcare system in Jamaica. We will then move into our conversation section of the webinar, which today will be a conversation between Susan, Joanne, and Dr. Julia Porter from the Ministry of Health and Wellness. We'd very much like all of you to be involved, so please use the Q&A tab to submit any questions you may have, and also use the chat tab for sharing any other thoughts and reflections you may have. We will try to address as many questions and comments as possible during the webinar, and in fact, we have Professor Sue Walker present in the background. Sue Walker is another core ReachUp team researcher who many of you will know, and she will be answering questions in the Q&A tab. We'll try to answer as many questions as possible during the webinar, and all questions, comments, and feedback will be reviewed by the Thrive team after the webinar. Finally, I should also let you know that we are recording this event, and the content will be made available afterwards on the event section of our website. You'll also find recordings of our previous events there too. So now I'll hand over to Susan so that she can talk us through ReachUp's amazing journey and their latest evidence. Thank you, Susan. You've got 15 minutes.
Thank you, Beth. All right, let's get started here. Okay, so I'll be talking about delivering an effective parenting program through the government healthcare system in Jamaica. So the Jamaica Home Visiting Program was developed to build parents' ability to promote their child's development through play and responsive caregiving. It is delivered by community health workers who conduct an interactive play session with mother and child. Several studies have shown benefits of this type of home visit to children's development. In 1986, a longitudinal study on the effects of nutritional supplementation and psychosocial stimulation on the growth and development of stunted children was conducted. 129 stunted children were randomly assigned to one of 4 treatment groups, and the trial lasted 2 years. The results showed significant benefits to children's development. Long-term follow-ups have also shown sustained benefits to adult cognitive ability, educational attainment, mental health, social behaviors, and income. In 2018, the WHO launched the Nurturing Care Framework that places responsive caregiving and opportunities to learn for children 0 to 3 as critical components of care for young children. Their guidelines called on governments to provide necessary support and services for families who are the primary providers of care for young children. The ReachUp Early Childhood Parenting Program is a training package based on the Jamaica Home Visiting Program and was launched in 2015. The aim is to increase the capacity of implementing agencies to deliver programs for children under 4 years and their parents in low and middle income countries. It provides curricula, comprehensive training materials, and manuals on toy making, adaptation, and planning. The key features of ReachUp is that it can be delivered by non-professionals. It's an interactive play session with parent and child. It builds the caregiver's ability to promote their child's development. There's a structured curriculum, which uses play and everyday activities to introduce concepts and language. The play sessions use homemade toys, songs, games, language activities, and picture books. Parents are encouraged to continue the activities between visits and to integrate them into their daily routine. There is an emphasis on building relationships between the health worker, the caregiver, and the child. Praise to the caregiver and child, responsiveness, and we emphasize a lot of fun and enjoyment. To date, ReachUp has been implemented in 21 countries. Meta-analysis of evaluations across 8 countries showed significant benefits for children's cognitive, language, and fine motor abilities and the quality of the home environment. In 2018, the Ministry of Health and Wellness here in Jamaica selected REACH-UP as part of their contribution to the National 0 to 3 strategy. It is implemented by the Family Health Unit and is called Early Stimulation Program. Home visits had started in 6 of the 13 parishes before the pandemic interrupted in-person visits. The pandemic also accelerated the development of remote delivery methods to facilitate continued delivery of ECD services, such as telephone calls, text, and audio messages. And around this time, in collaboration with IDB, we developed a parent manual with activities for parents to do with their children at home, and this was widely used in Latin America. Here in Jamaica, the Ministry of Health and Wellness restarted the program using these remote methods, including the parent manual. Evaluations of that showed that there were benefits to the parenting practices, and the program was seen as feasible and acceptable to parents and health staff, although the health staff felt that some in-person contact was necessary. So with the restart of home visits, together with Ministry of Health and Wellness, we decided to evaluate the impact of a blended model of remote and in-person delivery. The objectives of that study was to determine whether the REACH-UP program, delivered by the primary healthcare services, using this blended approach, did it have any benefits to the children's development and parents' behaviors? And the second objective was to determine whether the impact varied by child's age and sex, mother's educational level, or maternal depressive symptoms. Families were enrolled in July 2022. Participants were recruited from the communities served by the health centers in 12 districts across Jamaica. Informed consent was obtained before administering the baseline questionnaire. The intervention duration was 8 months, and the delivery was phased in across the districts from September 2022 to August 2023. Families were eligible if they had a child aged 3 to 28 months. If they were beneficiaries of the Jamaica Conditional Cash Transfer Program or known by the health staff to live in poor circumstances. Families were excluded if 1, the mother was less than 18 years due to the requirement for adult consent, the child attended daycare, child had no consistent caregiver at home, or if the child had a disability likely to affect their development. Families were identified by the community health worker and the nurses. 8 children were enrolled per community health worker in each health center. 4 were randomly assigned to the intervention, and 4 were put on a wait list to receive the intervention after the evaluation. All children received their usual care at the health center. The initial training of trainers, which are the nurses, health educators, and the nutritionists, was conducted in 2019. This workshop was conducted by the research team, and it lasted 10 days. These trainers then went on to train community health workers. Due to the COVID, there was a delay in the restart of the home visits, so there were staff turnovers and additional community health workers were identified. With that, we found that 76% of the community health workers had received the full training. We therefore had a 3-day workshop for all community health workers and the nurses, and this was to help them conduct phone calls, use the blended curriculum, and review several of the intervention methodologies. Supervision was also reviewed. The blended intervention had 3 components. The first was a parent manual, the same parent manual I spoke about earlier, that was given to all parents. Home visits or a phone call was conducted by the community health worker every 2 weeks, and the toys and materials provided for both contacts were given at the home visit. Text messages were sent out each week, And this was to reinforce play and language activities and to encourage the parents. At baseline, we measured the family characteristics, parent attitudes on child development, parent practices, maternal depressive symptoms, and some child variables. At endline, all the baseline measures were done again, except the family characteristics. We measured the children's development, the amount of stimulation in the home, and we did some in-depth interviews with nurses. The impact evaluation was conducted between May 2023 and April 2024. Results. 491 children were assessed at endline. This was a follow-up rate of 78.3%. There were 237 children in the intervene group and 254 in the control group. We found no significant differences by group in their baseline characteristics. Children lost to follow-up had younger mothers with higher school grade completed, and higher sanitation scores. These three variables were used to estimate the probability of loss and calculate inverse probability weights. This was then used to adjust for any bias due to loss in follow-up. The children's age at endline were similar in both groups, and they were about 27 months. And approximately 1/5 of the children had started attending preschool at the time of the assessment. This table shows the multivariate regression analysis of the intervention impact on the children's development at endline by group. And what we see here is that the intervened children had significantly higher developmental quotient and fine motor ability scores than the control group. This table shows the intervention impact on parent and home environment. And what we see here is that the intervened parents had significantly higher total home scores than the control group. This table shows the impact on the parent and home environment. And what we see here is that the intervened parents were almost twice as likely to praise their child when they behaved well most of the time than the control parents. And also the intervened parents made toys for their child than the control parents. Multivariate regression analysis were used to examine the heterogeneity of impact by a child's age, sex, mother's educational level, and maternal depressive symptoms. No variation in impact was found on any of these. So in summary, we found benefits to the children's development, specifically their overall development quotient and their fine motor ability scores. We found benefits to the caregivers' behaviors. They had more stimulating homes, they used praise more when the children behaved well, and they made toys for their child. The implementation and most of the costs were undertaken by the Ministry of Health and Wellness with some support from the research team. Impact evaluations showed modest benefits to the children's development and to parenting attitudes and behaviors. Benefits to parent behaviors and the home scores, specifically two behaviors, the use of praise and making toys, are core elements of the Reach Up program, and this suggests that the intervention led to gains in parenting practices. The intervention was only 8 months long, relatively short duration compared to the prior studies that have generally lasted 1 or 2 years. A longer intervention period may have allowed time for gains in parenting to contribute to larger impact on child development. So we did have challenges, and these are just some of them. So one of the first challenge you had was staff turnover, as the trained staff either left or were transferred. We had challenges with the training because due to COVID, there was a 3-year gap since the full 10-day training. So what we found is that we found that 1 in 4 of the community health workers did not have the full training. We had challenges with the supervision by the nurses, as monthly supervision was to be conducted by the nurses. However, the rates varied across the island. And when we did our interviews with the nurses, they spoke of the workload contributing to this. The community health workers missed some contacts with the caregivers, and this was due to caregiver inability, either at the home or on the phone, violence in the community, or conflicting duties, such as immunization drive in the school. So as the Ministry of Health and Wellness is scaling the program, they have rebranded and they have a new logo that's down at the bottom. Their brand name is now Early Start Bright Future JA. As Beth talked about, there is a 5-year plan for ECD that has been developed, and this includes a phased expansion of Reach Up and a universal parenting program based on Reach Up delivered at health centers, which we also evaluated. Thank you.
Thank you very much, Susan, for sharing with us those insights into Reach Up's journey, as well as your most recent research findings. So if anyone would like to read more about this study or any other Reach Up material, you can find links in the chat. Right, so now I would like to invite Joanna and Dr. Roe Porter to join Susan for the conversation part of this webinar. So to start this conversation, I would like to take a step back and reflect on Reach Up in a more global and historical context. So Reach Up has been in existence, as you mentioned, Susan, since the 1970s, 1980s, when the trial was there, and has built a strong evidence base, influencing many researchers, NGOs, and governments all around the world to invest in its curricula and implementation. And given this, some might have expected the Reach Up parenting model to be scaled nationally in Jamaica by now. At least I would have expected it. However, what we heard in your presentation just now, this has not yet happened. In fact, the partnership between Jamaica's Ministry of Health and Wellness and the Reach Up team only really began quite recently. And as I said, this might come as a surprise to many people in the audience, and I think we will all like to hear more about why that is the case. So Susan, maybe first you, what efforts did the research team, if any, make over the past decades to scale Reach Up in Jamaica? Did you attempt to scale either horizontally or vertically longer time in the past? And if so, could you please tell us any insights and perhaps some secrets about your experience, Susan?
Okay, thanks, Beth, for that question. So first, I'd like to say that the research team has always been in dialogue with the Ministry of Health and Wellness. And for the 1986 study, the community health workers that we hired were actually referred to us by the Ministry of Health. So there was always dialogue. We kind of started more of a partnership with the ministry as we did more studies within the health centers. And for example, one of the studies that they facilitated us with was to help us determine how feasible it was to integrate this program into the healthcare services. So they helped us with that. And in that study, we found that the program had a positive impact on the children's development, their parenting knowledge and practices, and maternal depression. And the way they facilitate it is that the community health workers that actually worked within the health centers carried out the program. So we did not hire them, they were used. And that study was a year or two long, and we found that it was feasible to now use the community health workers that were actually hired and working in the clinics. So we have been in partnership, and Prof. Walker says to me, so Suzanne, scaling is a process. So you couldn't just do it right off the bat with just one study. So currently, you could say our relationship with the Ministry of Health is a more formal one now that they've invited us to collaborate with the implementation of ReachUp and using it in their primary care services.
Thank you very much, Susan. So I understand correctly, there has always been a dialogue, but the more formal partnership started more recently. So thank you. So Dr. Roe Porter, if you don't mind, I really would like to know your perspective on this story. So what do you think were the ministry's concerns, if any, in the past, until you engage now more formally with this process, and what has changed recently that made you turn to ReachUp, the research team, now to engage more formally in this partnership?
Okay, thanks, Beth. So it's important to know that early childhood development has always been a political priority for the government of Jamaica. And we have our Early Childhood Commission that was established in 2003 under an act and as an agency under the Ministry of Education that really coordinates our national strategic planning for early childhood development since 2008. And this national strategic plan has been refreshed and renewed up till this moment. So early childhood intervention is ongoing for us. ReachUp has been a successful locally developed parenting intervention, and it gained a lot of traction nationally and internationally. And this is because, of course, it has such a solid and convincing evidence base. So implementation really was decided upon where advocacy peaked from the highest level from stakeholders in early childhood development, as well as our mental health teams, our nationally commissioned task force, and our violence prevention partners as well. Because the program really addressed unmet needs that we prioritize as a country, so high violent levels of violence and or concerns about the mental health of our population, and using a life course approach to addressing these problems. So there was really strong support for ReachUp implementation, and for the Ministry of Health, our Chief Medical Officer and our ministry's directorate really was resolute about having it implemented. And importantly, Jamaica's primary healthcare system was established based on a framework that has home visiting by community health aides for several programs, including immunization, epidemiological surveillance. And these health aides are supervised by midwives and public health nurses as part of routine child health services. So implementation of ReachUp fit like a key in a lock. And because ECD is a priority for the government of Jamaica, the Ministry of Health and Wellness has a protected budget line for child health and development. So funds, for key resources for child health programs were available. So ReachUp implementation fit well with this.
Thank you very much, Dr. Roe Porter. So you really nicely highlighted the importance of timing in the scaling journey, and that for an ECD intervention to be successful in getting 100% government buy-in, it should fit with the government priorities, like, as you said, a key in a lock. So the government really seems to have embraced now the ReachUp model, and that makes us wonder, Dr. Roe Porter, is there still any role to play in Jamaica by the ReachUp research team? And at what point do you think researchers should step back and allow full government ownership, if at all? Dr. Roe Porter.
Well, we will not be letting go of the care team anytime soon. We think the relationship we have with ReachUp is an excellent prototype of what the relationship between government and academia ought to be. Because, research is living and breathing, and evidence base is what we need to ensure that we are implementing programs. Government, especially Jamaica, implements programs all the time, but having the strong evidence base, especially evidence that is locally, that has a local origin, is really strong. And because the program evolves, data evolves, we really won't be letting them go. And we need to maintain the quality of the training ongoing. We own the program. We have a coordinator, so we're building on our coordination capacity, but we'll continue to engage with the care team for training and review.
Thank you, Dr. Roe Porter. So Joanne, would you agree with this perspective? And would you like to briefly maybe share your thoughts on this before we move on to the next topic?
Sure.
from researcher hat? Thank you.
Okay, thank you so much, Beth. So I think, so definitely Dr. Reporter hit the nail on the head. We will continue to collaborate with the government because there's a constant need for research to drive evidence-based decision making. And the government has the trained staff and capacity to own and implement the program. And we as researchers can partner with the government to do this. But I want to look at three different aspects. So we as researchers can help with periodic reviews in terms of monitoring and evaluation to ensure the intervention is delivered with fidelity. So we can assist the development of evaluation tools, but we can also help with training. And as the program is delivered, we can help with monitoring any further adaptations that are needed. But there may also be some societal changes as the needs of the government change, as the needs of the programs change. We can also look at access to new technologies or changes in communication methods. And these may require further research, and we will be there to assist and collaborate as well. And the training and capacity development. So as the program evolves, there will be a need to develop further capacity within the ministries, including retraining of staff and training new members to deal with issues of attrition. And I do believe that we will continue maintaining this collaboration for the long term as it has benefits for both parties. So we will be continuing.
Thank you, Joanne. So it sounds to me that everyone agrees that the Reach Up research team will continue to play an important role in the journey, either monitoring evaluation, training adaptations, or capacity strengthening. Thank you very much. So now I would like to all of us to shift the focus of our discussion to the recent study findings, the ones that Susan presented earlier, about the bi-weekly blended delivery model alternating a home visit with a remote phone call. So your findings suggest that the blended model resulted in, I mean, at least it was maybe not as clear in the presentation, but in the paper, we read that it resulted in perhaps smaller impacts than the original Jamaica Reach Up model, which used like weekly home visits. However, it was also clear from the paper that it significantly reduced costs, with the analog cost per child of the intervention being approximately 1/3 of the original trial. So Susan, do you see blended delivery as a temporary compromise or as a viable long-term model for scaling Reach Up in Jamaica? And what about parenting programs in other countries or other settings more generally? Susan?
All right, Beth. So the remote component of that blended model was actually developed during COVID. So I actually see the use of the blended model as maybe temporary for maybe special situations like COVID, or for families living in quite remote areas, or during extreme weather conditions, natural disasters, or even during social unrest. So for those situations, I think the blended delivery may be a better compromise. But, you know, it was made as a temporary intervention.
Thank you, Susan. So Dr. Reporter, what are your views on this? So from a government budget and service delivery perspective, how attractive is the blended model compared to a perhaps more intensive home visiting only approach?
Well, the blended model using the phone calls with the home visits, it serves its purpose during the pandemic, as Susan said. And, you know, it was used where services were disrupted or home visits were disrupted. In our context, there may be concerns, for example, using phone calls are at a cost to the health service because we'd have to buy phone credit for the team to make that contact with the parents. And also, in the deep rural setting, phone connectivity and internet connectivity is really not very good. So it may be more difficult in settings like that to do phone calls. And we just find, because of how our primary system runs, face-to-face contact, going into the communities really works better. It's more feasible for a remote setting. So we may find that, where there are disruptions, for example, our community flare up in violence, we may have to revert to the use of phone calls. But we think the home visiting is really what we want to continue with. There's another model where we do health center education. So we blend that with the home visiting, and we think that's working well for us so far.
Thank you, Dr. Porter. Yeah, it's interesting because a lot of people are now considering having a blended approach and doing more remote parenting. And it's interesting that from the Jamaica team, who are really have a lot of experience in this, that perhaps, you know, it's not for all settings, but more for specific settings, as explained also by Susan. So Joanne, is there anything you would like to add to this before we move on to the next?
Sure. I just wanted to highlight that there are two programs that also implement Reach Up using remote delivery methods. So in Brazil, the intervention has been delivered using WhatsApp. And in this setting, WhatsApp is freely available or widely available to most of the population. So your child development agents there, they send pictures and mothers can send videos about their interactions with them, with the children and doing the activities. And this started during COVID-19, but they have maintained it because the parents have remained engaged with the intervention. And in Guatemala, the intervention has also been delivered using voice messages to caregivers. So the Reach Out program has increased. So I do believe a blended approach is good, but also remote delivery can work depending on the setting. Thanks, Beth.
Thank you. So to close this conversation before we move on to the Q&A session, it would be really nice to reflect more on the fact that the Reach Up parenting model has been successfully replicated at small and larger scale around the world, and researchers and practitioners have been experimenting with adaptations to make the model suit local circumstances and make it feasible to implement at larger scale. So Susan, what are your views about the adaptations of the Reach Up parenting model that you have witnessed around the world? So if you were advising a country that already recognizes the effectiveness of parenting progress, but struggles with implementation at larger scale, which features of the Reach Up model do you think could be adapted? And which features do you think must be preserved to maintain impact? Susan.
Okay, Beth. So yes, the model has been replicated successfully at smaller scale. However, what we've learned from some of the countries that are implementing at a larger scale, like Brazil, is that we need to maybe reduce the number of materials. We're talking about the toys, the things that are used for the activities. They're at a larger scale is kind of impossible to replicate so many of them. So we need to kind of reduce the number. However, we need to keep a core set of materials, materials that can be used for multiple activities, so that children can learn multiple words and concepts. For example, like blocks, quite versatile toy, doll, and books. Also, while we're reducing, we could maybe substitute some of the materials with things that are found in the home or in the environment, in the surroundings around the home, and that would help to reduce the number of materials. The features that I would keep, though, is maybe definitely the in-person delivery. A core feature of Reach Up is the use of positive interactions like praise for both the child and the mother, and just having fun during the visit. So visitors use these kinds of behaviors while doing the activities with the mother and child in the home. And what we see is that it helps to strengthen the relationships between the visitor and the mother, the visitor and the child, and more notably between the mother and the child. So interpersonal relationships are being strengthened, bonding is being strengthened, and they're also learning social skills. Also, when we do these in-person demonstrations, the mothers are encouraged to do the activities, so they actually see the demonstration. So hopefully that will reinforce that they know how to do the activity. And then the communication will also help to encourage them to do the activities between home visits. So that is what I would do. The features that, that can be adapted, or those features that should be kept.
Thank you, Susan. So, Dr. Will Porter, we hear from Susan that one of the features she really would like to keep is the whole in-person home visits and, like just having fun, which I think sounds really nice. But what do you think about this? So we heard in the presentation that even with the less intensive blended model, community health workers missed some household visits, and monthly supervision by nurses was inconsistent in certain areas due to workload and competing demands. So Dr. Reporter, from a more systems perspective, what, if anything, do you think might need to be modified in the program design, especially regarding perhaps workforce training or delivery, incentive, supervision, and anything? Dr. Reporter.
Okay, well, I think it's important to highlight that the program has an excellent delivery system grounded in feedback and supervision. And we can't lose that element of it at all, because that maintains the quality of the intervention, and that's key. We do recognize that we have staffing constraints, especially with shortages of nurses and midwives in the field. And that really affects not just Reach Up, but all primary care programs. So we have ways to try to, mitigate that. We are grateful, though, that we have had an infusion of community health aides. We've recruited many of them in the recent past, and we have incorporated them into Reach Up. So we have more foot soldiers to implement the program. But I want to highlight that it's important to establish accountability to the existing supervision and reporting framework for child health. And we want to avoid creating a siloed vertical program. So the pilot happened, it had to be vertical because it was research, but then now we have to try to implement it or integrate it into the system more properly. So, and that would entail our parish health departments and our regional health authorities receiving programmatic reports, reviewing service delivery and performance gaps, and empowering them from the national level to address the challenges that have been identified with the support from the national level. So that's important, to use existing framework reporting and supervision, and we must have ongoing training. That's critical, and set program targets. So looking at the populations, ensure that they're given a targeted number of families to reach, and have that monitoring and review at a programmatic level so that they're held accountable. And lastly, I want to say there is about it in drawing on partnerships from our community. We have, for example, our elderly health program. We can integrate our elderly in the community to help with toy making, So looking at opportunities for integration and community support, I think, would help the program to be sustainable and thrive.
Thank you, Dr. Reporter. I think that also already answers some of the questions that I saw in the Q&A box. Thank you so much. So now I'd like to turn to more questions from the audience. So I know that some of them have already been answered, and please continue posting questions in the Q&A tab as we start this part of the webinar. I'm now just going to go through those that have not been answered yet by Sue Walker. So let me have a look. So I think one of them, which I think is quite interesting, and I don't think it's been covered yet in the conversation. So the question is, I'm eager to understand why the Ministry of Health is often preferred to lead interventions in parenting programs. How does the health system collaborate with other institutions, such as the Ministry of Social Affairs and the Ministry of Education? Furthermore, what role do social workers and the broader social sector play in ensuring the effectiveness of parenting programs? I don't know maybe Dr. Reporter, you want to go first, or anyone else?
Okay, well, that's an excellent question. Well, I think it's really because of our primary care system and how it's structured, where it's community-based, and the health system has a really great reach. Our immunization coverage is 99% for most antigens. So, and that's national, public, and private sector. So the reach for children in the early childhood cohorts is significant versus, say, for education and children attending an early childhood institution. The proportion of our population is probably smaller because a lot of them are at home. So it really is a great opportunity to have a wider reach through the health sector because of our child health surveillance system in Jamaica. And you ask about social security, social protection. The children that we target is through the conditional cash transfer program that Susan spoke about in her presentation, which is called PATH, Program of Advancement Through Health and Education, which is run by the Ministry of Labor and Social Security. And those children engage with our health centers, they engage with our educational institutions. So there's really a triad in our system for our early childhood cohort between health, education, social protection. We target children on path and those that are vulnerable. So we do have that relationship with social protection. We partner with our education sector. All our health centers have excellent relationships with the early childhood institutions. So it's really synergistic, especially, and it fits well with the Early Childhood National Strategic Plan. We report to the Early Child Commission on the activities that we have, and the Planning Institute of Jamaica as well.
Thank you, Dr. Reporter. Anything you want to add, Joanna or Susan? Or shall I move to the next question? Has everything been said?
The only thing I wanted to add was a lot of the focus on early child development would be in the first 1,000 days. And usually the Ministry of Health would be that particular agency that focuses on children within that age group. So that's why it's kind of a very good ministry or government agency to start with. But as we move, as the child ages, there needs to be some synergy going forward to help with continuity. So that's all I wanted to add, but thank you.
Thank you, Joanne. So then I see quite a few questions related to, the next steps in terms of scaling. So there are questions like, how do you envisage the upcoming 5 years in terms of scaling? What does the panel think are the next milestones in the scaling journey, and what needs to happen to make the next milestones a reality? What might stop these next actions to take place? So I don't know, Susan, do you want to go first, and then maybe we ask others if there's anything you want to clarify here?
Well, the plan, the 5-year plan, has a lot of how to increase the delivery. So there are people out there encouraging and bringing on more of the health centers into the program, and so we're definitely doing that. We can't start everybody one time, so we're slowly phasing in and adding more health centers to use the program. And there's also another program that is based on Reach Up as well, which is more universal because it is shown in the health center and done in the health center while the parents are there waiting. So there are those two programs that we're slowly getting to on board, with more clinics coming on board. I don't know if Dr. Reporter wants to add to anything to that.
Yes, to add to that. So the health center-based program, Baby Matters, that one is actually that has a lot more traction. It's a little easier to implement because it's based at the health center, and you teach the masses in the waiting area. And we think that is helpful because it helps with raising awareness. We've also placed the messages from Reach Up in our child health and development passports. So, loving your children, playing with your children, reading to them, all of them are in a passport that every child born in Jamaica gets at birth at the hospital. So part of the program is raising that awareness. So that's part of our 5-year plan. We've done that already as of last year. Every child is getting the messages, plus the Baby Matters program with the health center education. And then now Reach Up with respect to scaling that program. Even if we don't get to the stage of having all health centers offering it, we want to at least make sure that the most vulnerable have access to it, and that there's a referral mechanism where those children in the community that are most vulnerable can access the home visiting. But we want all parents to be exposed to the parenting messages, and that's building through some element of the program, the Baby Matters, as well as our passports and our partners as well.
Thank you, Dr. Reporter. Then we have more questions, more general questions about the core challenges you've faced so far. So, someone says it has been a long journey. Which one which one you identify as the main challenge that you have encountered to this point. Has it been resolved? How do you manage this challenge? And I think someone else mentions the challenge of turnover, whether you have any workaround solutions that worked for you at this point. Who wants to answer this question? They don't address anyone in particular. Dr. Reporter, you want to go first, and then we move to the others.
Sure. So I think training is probably the biggest challenge because it's a 10-day program, and we have over 300 health centers across the island, and there are over 40 that are have implemented Reach Up. So to scale it is not just going to entail spreading it to the other health centers, but ensuring that we retrain at the current sites. So to address that problem, we have a national coordinator in place that is doing that training, but we're going to have to now decentralize training to the regions to a lower level in the system so that there can be that ongoing training support closer to the field level so that new sites are trained and the current sites, training continues to be ongoing. So, and the budget, we have the blessing of our ministry to go ahead and ensure that training happens and that scale up and maintenance is effective.
Thank you, Dr. Reporter. Susan or Joanne, you want to highlight your main challenge that from your perspective that you encountered, or is it in line with what Dr. Reporter just said?
The only thing I wanted to add would be that one of the challenges as well. So when the home visitors go out into the communities, sometimes the parents may not be at home or may not be available for different reasons. And as you would imagine, when economies change, so when mothers are no longer staying at home, but they're going to work, then doing the home visits might be a little more difficult. And doing the home visits, we do leave materials in the home, and having to replenish those materials to the resources to keep replenishing those materials, making toys, having them available was also a challenge. So having to overcome that may be something that we need to think through. And as Dr. Reporter stated, having it spread through decentralized to a regional level where the regions can help with the toy making and helping to provide resources for that can help. But we also need to think when you're scaling, you need to ensure that you maintain the quality. So having to be able to monitor and check the quality to ensure the toys are being made in an appropriate way is also something that that was a challenge, but also needs to be taken into consideration.
Thank you, Joanne. So as part of the challenges, none of you mentioned now how to motivate the workforce. So, I mean, there's of course the training. So there's some questions actually about that in the chat. So people ask, how do you motivate the nurses and the midwives, the supervisors and the persons who are delivering the intervention? Were health workers incentivized in any way to do their part, or were they pushed or forced by the ministry? If incentivized, what incentives do you think really worked and what perhaps did not work well? Maybe Susan, you want to go first, and then we can ask the others.
Yeah, there is a challenge with motivation. In our case, we try to remind our community health workers that it's not additional work. It is work that you're supposed to do. You're supposed to go into the community. You're supposed to do home visits. But every now and then, if you find a family that needs Reach Up, then that can be the type of home visit to use. So we're trying to show them it's not extra work, but a part of their job. Motivation is quite hard otherwise as well. What we're trying to do too is, as the new set of community health workers come on board, we're actually exposing them to Reach Up so that they learn about early childhood development. They learn how there are activities that can be done to help further the development. So we're trying to infuse it before they actually so they realize it's part of child development. There may be need for more incentives because, going out there, the sun is hot. They have to walk because in the rural areas, there are no real buses that go to some of these areas, so they have to walk. We do have some regions where the head supervisor nurse is quite on board. So that helps as well when the senior members of the health region is on board. They're more likely to encourage the nurses and the community health workers at the clinic level to do it. So when you have somebody as high up as even Dr. Roe Porter, who really is a champion for Reach Up, that helps with that kind of motivation. With the incentives, it costs. So I don't know what they can do to help. So I'll turn it over to Dr. Roe Porter.
Okay, thanks, Susan. Just to add, because it's now a full-fledged program, what we do with our other programs, for example, immunization, when they're doing well, we have our review meetings and we give them trophies and we pick them up and we showcase the best practices. We haven't yet done that for Reach Up, and we're planning to do that in the short term. And I think that will give it a major boost when the country sees these champions going out into the field and making such a difference in the lives of children. So, that review of the program and an awards ceremony without monetary incentives, that kind of motivation really we've seen works with our programs in the primary care setting. So that's what we plan to do in terms of incentives. And like Susan said, getting the supervisors on board to address whatever motivation challenges, and they do their motivation at the local level as well. So this is really just it being transformed into our program and making sure that we meet our targets and highlight the successes and learn the lessons and move forward.
Thank you, Dr. Roe Porter. I think I have one final question for you, Dr. Roe Porter, and I think you can have 30 seconds or 1 minute to respond. It's a bit more challenging, kind of a more global question from someone in the audience who asked, how could scaling move faster than the growth rate of the wider economy and average public spending rates? What national arguments gives ECD scaling the highest government spending priority? And I think this is kind of linked to, in the paper I saw that the return to investment, like for every dollar spent, you get a return of $12 in terms of future earnings, right? So is that enough for an argument? Like, is that something discussions you've had to really kind of go faster? Is that something that matters?
You can't go fast with something like a plant to grow roots and thrive and bear fruit. You can't rush that. So one word or two, life course approach, or is it actually? Mm-hmm. Life course approach, we take it very seriously in health. You start from early and you get the gains later. And that takes time and it takes investment, and we're ready for it.
Thank you so much. I'm afraid that's all we have time for today. So thank you very, very much, Joanne, Susan, and Dr. Roe Porter for joining us today and sharing with us these amazing insights that we would otherwise not get access to. And I think one of the many things we learned today is that scaling is not just a technical challenge. I think it's also institutional, it is political, and it's most of all, it's human. So thank you very much for sharing those insights.